All right. Why is the developing brain so susceptible to injury?
The vasculature in the three-term brain doesn't dilate well, so as arterial pressure drops, the perfusion pressure also will drop, leading to myelinating.
There you go. Yeah, that has a lot to do with it. And there's also a lack of myelination at that point. So neurons are, they're not as energy efficient. So they really need a constant supply of blood. And that can be difficult to do. How about border zones? First of all, what are those? And then what makes them typical sites of ischemia? Jake, thank you for volunteering.
Border zones receive blood supply from the most distal branches.
The most distal branches. Okay. So that means they're further away from that circle of Willis.
Right.
As you go further away, what happens?
So those terminal arteries are fine and have high containment.
Fine meaning they're good, or what do we mean by fine?
No, as in small.
There we go. They get thinner, yeah. Smaller diameter, higher resistance. Yeah, so that smaller diameter means it's more difficult to force blood in there than a big wide vessel, and it's also easier to clog it up. So that makes them susceptible to ischemia. We're going to forge ahead. If that's all right, this is your class. Okay. Then we will. Let's see here. Hey, last week had a Friday in it. Sorry, I forgot to come here. I don't know if you guys forgot to. Anyway, it's easy to forget because there's other things going on Friday. Friday's a great day, but I want it to remain a great day, so I'll be here this Friday. You can come by if you have questions. I put it on the Google Calendar because I need it. I need it on my calendar, or I'm going to forget. You want evidence? See last night. Today, like Friday, is also a great day because exam 2 regrades are due. So make sure I get those. There's a pile here. You can add yours to that. Just make sure I get it today. I just want to clarify a few things in regards to last lecture. So when we're talking about dystonia, we need to keep in mind that this is fairly rare. I think that the wording in the book might have been a little confusing, perhaps. So just keep in mind the dyskinetic forms, where you see choreic movements or dystonic movements, those account for at most 10% of cerebral palsy cases. And while dystonia might sound a lot like spasticity, they are not the same thing. With spasticity, we're not necessarily getting involuntary contractions. Instead, we're getting hyperreflexia. So there's a reason why we get excess muscle movements. It's because of a pronounced reaction to some sort of sensory input. It's not just involuntary, spontaneous contraction. That's what we see in dystonia. And there's two different underlying causes. Even though they both translate to an increase in activity of the muscle, dystonia seems to be caused by an increase in upper motor neuron activity that's driving the activation of lower motor neurons. So it's a more central case of increased muscle activity, whereas spasticity is caused by a severing of those upper motor neurons, or a decrease in upper motor neuron activity, allowing the reflexive pathways to drive lower motor neuron activity. They do sound similar, but they are quite different. I hope that's clear. Okay. That's old stuff. We're going to move on to new stuff now. Today is about seizures and epilepsy. So abnormal bursts of activity. There's a variety of causes for these. Seizure activity has come up in earlier lectures. In epilepsy, seizures are not driven by some some known cause, like a head injury, stroke, cancer. There's something else driving it. They're what we call unprovoked seizures. It's not that you have some mass lesion pressing on the neuron. There's usually some abnormality with the neuron. We'll talk about those in a bit. Again, two parts, just like most other lectures. So we'll talk about kind of the signs, some of the different seizure types that exist, prognosis for epileptics, and then we'll talk about what's going wrong and what can we do to treat that in the second part. Epilepsy is fairly common, I suppose. About 1 to 1.5% of the population in the U.S. that'll have epilepsy. Depending on where that epileptic activity occurs, you might have motor, sensory, or cognitive abnormalities. You might have all three. It depends on how focal or diffuse these seizures are. Now, the seizure itself is the event of neuronal hyperactivity. Seizures have a beginning and an end, and epilepsy would be the condition in which you see recurrent unprovoked seizures. So the epilepsy is the condition, and seizures are the events that occur in that condition, and others. Just because you have a seizure doesn't mean you have epilepsy. You might have a brain tumor, or there might be a cerebrovascular cause for that seizure. Or it might be a psychological cause. You might not actually see any abnormal EEG activity. In the case of epilepsy and seizures with a biological as opposed to psychological basis, you will see abnormal EEG activity. So here's normal. You can see fairly low amplitude oscillations detected in EEG, and that makes sense. We're trying to measure electrical activity through the hair, if it's present, scalp, skull, meninges. We're pretty far removed from the actual source of electrical activity. So we're looking at really microvolt oscillations from a large number of neurons, which should be asynchronous. They shouldn't be all acting together at once. And because they're not acting together at once, we get very small deflections. Only whenever you have large areas of neurons acting in synchrony do you get appreciable electrical events that you can measure through the meninges, skull, scalp, hair there. And that's what we're seeing on the bottom. Notice the change in amplitude. Here, T8 and T8, so it's a temporal parietal source. You can see these sort of larger oscillations here, much greater than what we see in this normal EEG up here, or even in this frontal measure right here. So larger amplitude oscillations, suggesting that we have a large number of neurons firing together. Their synchronous depolarization is going to create larger amplitude EEG responses. These will eventually be transferred to other brain regions. We can see large deflections in other electrodes as well. So these high amplitude bursts, this is typical in seizure activity. So this is what we call epileptiform activity here. You don't always see it. And when you see it, there's not always an obvious seizure. So they don't always go together perfectly, but they do go together quite well, yes.
I feel like I'm missing something obvious, but if you're doing like an EEG after the fact, how's it showing you like past brain activity?
It doesn't show you past. So what you do is hook up EEG and then monitor over time.
Oh.
So they'll just have a little portable monitor that they wear. They'll wrap gauze around, maybe they'll put a scarf on so it looks kind of different. But they're going to record over time and wait for a seizure to occur and see if they can detect this. So this will be after you've had a seizure event to see if they're going to recur, and if they do you see abnormal EEG? And you should in the case of epilepsy.
So there'd be no point if someone had a seizure of doing like an EEG on them just one time and not tracking it?
Probably not. No. Unless they have seizures that are very frequent, and you're going to catch one in that very brief period of time. Infrequent seizures, you're going to want to track over time. Yes?
Well, so if you have a bunch, will it show change in these? Just baseline? They're not experiencing one, will it look different than someone who hasn't?
Oh, in the like post-ictal phase, so after the seizure's done, do things?
Does it change how these waves look just normally?
No, it's during the seizure where you see the abnormality. Yeah. EEG, it has really nice temporal resolution, so you can detect things really quickly, but there's very little information that you get beyond that. There's no spatial information. You don't know where the seizure is coming from, and you can't look into the past or anything like that. It's very hard to say that anything's abnormal, except in this case, during the seizure. And so this is just a little blow up down here. So you can see those large amplitude deflections. Here's a very large one that's actually overlapping with the other electrodes. And if it's going to be epilepsy, you have to have recurrent, meaning more than one, unprovoked seizure. So it's not caused by a head injury, tumor growth, things of that nature. There's some underlying cause. I want to point out status epilepticus here. So this is a form of epilepsy where you have prolonged, meaning greater than 30-minute seizures. And they often occur at high enough frequency that you get no break between the seizures. So you can have sort of overlapping seizures occur. When they occur, these are generally treated as a medical emergency because they last for so long. And we'll look at some data on why greater than 30-minute seizure is not a good thing. Here's a young girl. This is about 11 hours into it. So these seizures can last for very long times. Most seizures are going to be much briefer than that. Certainly under 30 minutes, under 15 minutes. But when you have prolonged seizure activity, that's status epilepticus. Now, as far as seizures go, I think we can make a couple there's a lot of different ways of describing them. I think it's much simpler if you just think about a few different binary options. Are they focal or are they diffuse? That's your first big difference there in seizures. Is there a very small area of the nervous system that's affected? In the case of partial or focal seizures. Or is it a larger area? That would be generalized or diffuse. Obviously, more focal seizures tend to have fewer signs and are less severe than the generalized seizures. In the partial seizure category, again, another binary decision. Do you have consciousness affected? If not, we call it a simple seizure. Simple partial seizure. If consciousness is affected, then it would be complex. So here we can see a simple partial seizure occurring. It's localized to the face, particularly the lower portion, although we're going to see the eyelid get involved later on the left side. Only one side of the face. That makes sense if it's a focal seizure. It's going to affect a very small portion of the nervous system. We control different sides of our body with different sides of our brain. He is still conscious for this. He's aware of what's going on. He just doesn't have control right now over his facial muscles on the left side. Because he still has consciousness intact and it's affecting a very small portion of his body, we call it a partial simple seizure. And they usually resolve fairly quickly like this. Not extended for 30 minutes or more or 11 hours. Fairly quick. In a complex seizure, there's going to be some alteration in consciousness. They don't necessarily pass out. It might be so subtle that they don't really notice it until it progressively worsens. Untreated seizures tend to worsen over time or spontaneously get better. So it's a mixed bag. Sometimes you'll get about a 40% spontaneous remission, and those that don't, they tend to worsen over time. More generalized seizures are going to affect larger areas of the nervous system. We got a question. Okay, thank you.
I have like a family friend who seizes like in the middle of the night, like while they're sleeping. What like would that classify? is that altered consciousness kind of? That's just like hard to tell.
Oh, yeah, I don't know. I mean, you'd have to, it would have to be while they're awake to know whether or not it's being affected with consciousness. I guess you could at least distinguish partial or generalized. Is affecting very small areas of the body that have any movements associated with it, first of all.
I don't know.
Don't fry.
I'm not in the, well, I'm not in the middle of the night there. She's
Yeah.
like my little sister's friend who's like 12.
Oh, okay.
It's sad. But
Okay. Well, without knowing more, it's kind of hard to say.
is there like a particular reason that things like happen when they're asleep rather than like awake, you know, like in the middle of the day you see? Is there a difference?
There must be. I don't know. It probably has to do with different activity in the thalamus. That's pretty widely connected to the cortex. We'll see the thalamus is the biggest spot for at least some seizures. I'll see what I can find on that. And it might be nothing, but I'll give it a shot. It is a good question, though, because there are some cases where seizures won't go on during the day. All right. Now, generalized seizures are going to affect larger areas of the nervous system, and as such, they're going to affect larger portions of the body. So here's a gentleman who has grand mal seizures. He's just coloring right now. As you can see, they have the EEG hooked up. So we're going to see two phases here. There's going to be an early tonic phase where there's an increase in muscle tone, usually causing jerking of the limbs. That's what we see there. You're going to see that his entire body is affected here. Often these will transfer from one hemisphere to another, so the source, the seizure focus might not be bilateral, but because of the connections between the two hemispheres, it will spread to both sides of the brain and thus affect both sides of the body. So now we're transitioning from the tonic phase into the clonic phase. So now we're going to see some jerky movements. We'll get into that here. They should affect both sides of the body. What they're doing here is trying to secure the airway. They're going to deliver oxygen here. They're also going to make sure that he's not going to choke on his own saliva. You'll see increased salivation in these seizures as well. Not only do we have increased output of our somatic nervous system, our autonomic nervous system is also stimulated, of course, and that's going to stimulate salivation. You can think of that as kind of the jerky contractions of the salivary glands. So here they're making sure he doesn't have any sort of respiratory issues in this case. So these, of course, are, because they're affecting greater areas of the nervous system, far more devastating than a partial seizure. Now, petit mal or absent seizure won't have motor symptoms. That's strictly going to be loss of consciousness. You might see blank stare or something like that, lasting up to about 15 seconds. So, with partial, does it affect consciousness? If so, complex. Generalized, does it have motor output? If so, it's probably going to be grand mal in that case. If there's no change in motor activity, then we're going to see just an absence seizure. Yeah.
And the grand mal start off as a petit mal.
You will have alterations in consciousness with the grand mal seizure, absolutely, and that comes on fairly early in it. And so maybe you can see it a bit in his face. It kind of goes a little blank, and then he jerks. Well, doesn't really jerk. He slowly turns to the side there and starts seizing. Consciousness is affected in both of these. And that's why the distinction there is going to be, do you see that tonic and clonic movements occurring? If so, grand mal. If not, if there's only a loss of consciousness for a brief period of time, that would be an absence seizure. But in order to have complete loss of consciousness, it can't be focal. These changes are more subtle, whereas these cause essentially a blanking of consciousness. There's just a period where they're gone, and then they're back. Yeah?
Are these seizures painful at all?
I would imagine. I don't know. I'll see what I can find on that too. I got a lot of homework. So sleeping and pain. All right, yeah.
Is
if it's loss of consciousness, wouldn't they not really, like, either not remember the pain or?
I don't know if there's pain after the fact because of the extreme muscle contraction and jerking. I don't know if they injure themselves. Certainly, you're going to have pain if you fall. And falling is a big risk here, especially with loss of consciousness. Yeah. So if you're not sitting or laying down in that case and you fall, certainly you're going to wake up with some pain. Yeah. Yes.
Tonic, clonic, is that just like a hyphenated way to describe the muscular contractions, or are those two different kinds of muscular contractions?
Oh, so there's two different things going on. So tonus, muscle tone. So early on, you'll see that he just kind of tenses up, and that's going to cause, it can cause some parts of the body to move, but you're not going to see big kind of spastic movements. That's going to be in the clonic phase, so that's where you see clonus. So they are two different types of things going on. So notice there's a turning of the head there. Okay, increase in muscle tone is going on. You're going to see him really tense up. That can create some small jerks, but they're not the same that you see in clonus. So the tonic phase comes on first, and then we're going to see more pronounced jerking movements bilaterally. This is still an increase in muscle tones. We're still in tonus here. And then you'll see much larger movements as he moves into the clonic phase. So they are different movements. All right. Muscle tone doesn't seem quite as high here, and then you can see the movements right there. There you go. So very different. Yeah.
Maybe Steve, with the loss of consciousness, is there always amnesia associated with it?
Certainly during the period where they're unconscious. I don't know if there's any sort of anterograde amnesia after the fact. Sleep, pain, amnesia. Somebody email me this. Okay. The risk factors for epilepsy are highly variable because there are many ways of causing a neuron to be excited. There is certainly an underlying biological cause. We can tell that because people with a first-order relative with epilepsy have a higher prevalence of developing epilepsy themselves. It's a little over a 3-fold increase in their risk. So to some degree, there's heritability, but we haven't identified just single genes that are associated with every case of epilepsy. They're all different because there are many genes that interact together to control the excitability of neurons. Here's just a few, and this is not supposed to make sense, don't worry. This is just to highlight that there's a lot of stuff that works together. There are many proteins that contribute to the activity of neurons, and there can be mutations in many of them in cases of epilepsy that could underlie that increase in neuronal activity. Mutations in sodium channels, for example, that increase persistent sodium current. Those could easily contribute to epilepsy. Mutations in glutamate transporters. Mutations in proteins involved with vesicle release. If we don't properly regulate neurotransmission, that could easily underlie an increase in neuronal excitability. Maybe we don't release GABA as readily, or maybe our GABA receptors are mutated. We do see that in some cases. Pretty much anything you could imagine, you can find it in someone. Potassium channels, sodium channels, GABA receptors. There are many ways to hyperexcite a neuron. We'll talk about those more in the next section. And then there are environmental triggers that can stimulate seizure activity. They all affect activity in the nervous system. Flashing lights can stimulate seizures in some cases. So if they're trying to see whether or not a child has epilepsy, for example, after a seizure, they might hook them up to EEG and then do a strobe test, where they hit them with flashing lights and see if they can stimulate a seizure in a controlled environment, to see whether or not they epilepsy. It doesn't work in all cases, but certainly those flashing lights are going to stimulate the nervous system. Illness, fever, allergies, inflammation, in other words, it's back. I don't know if it's ever left. I think it's come up in every disease it's talking about, but it's still here. Heat, especially in young children, can lead to seizure activity. Febrile seizures occur in about 5% of infants, something scary like that. So there are many ways of hyperexciting neurons. There can be genetic contributions, and then there are also environmental factors that contribute to it as well. The diagnosis of epilepsy does require recurrent seizures, meaning more than one, and you have to detect abnormal EEG activity. Seizures can occur in the absence of abnormal EEG. There can be psychological factors that underlie these seizures. That's not epilepsy. In epilepsy, we have measurable abnormal neuronal activity that coincides with the seizures. Here it is again. Notice this pre-seizure period here. Normal, low amplitude EEG. Hopefully the onset of the seizure is fairly obvious to us. Look at all these high amplitude oscillations there. Here's your seizure activity. There are other diagnostic measures that you can use to try to determine the source of seizure activity to see is it really epilepsy or not. Because these seizures need to be unprovoked. Meaning there's not something that we know of that's causing it. There's not a mass lesion. There's not a hematoma that's now pushing on the brain. There's not a cancer. You didn't have a stroke that deprived neurons of glucose. ATP levels drop. Sodium potassium pump doesn't work, et cetera, see units 1 and 2. So you could look for hypoglycemia. Maybe that has something to do with it. Maybe they have abnormally high levels of glutamate in their CSF, suggesting that maybe they have glutamate transporter impairment, something like that. Infection, again, inflammation, that could be driving this. CT and MRI are useful for ruling out mass lesions. But there's no pathology that's associated with epilepsy. You won't look at MRI and say, oh, yep, epilepsy. You'll just say, not a tumor. So you can rule out with MRI and CT. In order to rule in, you need that EEG. Yeah?
Just to clarify, but so up there it says that those are the requirements for like the definition of epileptical and EEG. But to be diagnosed with epilepsy, you have to have that plus the seizures, and they have to come together, or they don't have to come together?
Yes.
Okay.
Yes, the seizure should be accompanied with abnormal activity in the EEG, and you shouldn't have something else that explains it,
right,
like tumor, cerebrovascular insult, infection. In that case, you just have inflammation driving neuronal activity. Treat it, everything's fine. With epilepsy, there's something else causing it. Maybe some channelopathy or something like that. It's a good question. There's a slight increase in mortality rates. Well, I say slight. They're about 2 to 2.5 fold higher, but mortality rates are so low these days, it's still negligible. So the change in life expectancy is 2 years, maybe 10 years in the worst cases, on average. So they still live fairly long with epilepsy. Of course, the more severe it is, the more severe the impact is on life expectancy. Now, the cause of death is not always clear. I think about half the cases, there's no underlying cause. Certainly, patients with more severe forms of epilepsy, like status epilepticus, are going to have a greater reduction in their life expectancy. In children or adults, you'll see about 3% in children, 10% in adults, with their death occurring during a seizure. That's not to say that when you have a seizure as an adult, there's a 10% chance you're going to die. That's a 10% chance that you will die while having a seizure. You'll have multiple seizures though. So here we can see the mortality in status epilepticus. So greater than 30-minute seizure, less than 30 minutes. Somewhere between 10 and 29 minutes. So certainly a more severe seizure, but not status epilepticus. We're looking at mortality in kids, young adults, and the elderly. Not surprisingly, there's an age-dependent increase in mortality, just like life. When you compare these two groups together, you can see that patients with status epilepticus have higher mortality rates than those with less severe seizures. This shouldn't be very surprising. The seizures that resolve spontaneously were never associated with mortality in the next month. 0% of those patients died. Those that required treatment, in other words, those that were more severe, that didn't resolve spontaneously, that needed benzodiazepines to control them, 5% of them died. Status epilepticus, doesn't even matter whether they were controlled or not. There's an elevated rate of mortality in both cases. Obviously, fall risk is elevated in this population, especially if consciousness is affected severely. So swimming can be very dangerous. Even just drinking can be dangerous. And there's an increased suicide rate. Yes?
If status epilepticus is considered a medical emergency, why is it when it's treated there isn't like any better results?
I don't know. Likely it has to do with the fact that they have more frequent seizures, and just because the one that they measured required treatment doesn't affect what happened the month after that. It's not a great answer. It's me saying I don't know. Okay. Suicide risk. Epilepsy certainly does not improve quality of life. It's associated with depression, anxiety, and suicidal ideation. These all go together. People with depressive disorders tend to have anxiety disorders and vice versa. What you can see here is that the severity of epilepsy correlates with the instance of depression, anxiety, and suicidal ideation. We'll start on the right. On the bottom up here, the white bars are healthy controls. They're on the right in all these cases. Notice they're the lowest. And as your epilepsy worsens from being well-controlled, poorly controlled, to uncontrolled, you see an increase in rates of depression, anxiety, and suicidal ideation. Their suicide rates are higher than non-epileptics. So this could also contribute to the increase in mortality. Suicide is a major cause of death, really in all populations. But there's some good news. There's often spontaneous remission. Across lifespan, about 40% of epileptics will have spontaneous remission. You can improve your odds by controlling epilepsy, by controlling the seizures when they occur and not leaving them untreated. Why this occurs in the next portion here. But treatment certainly matters. In almost all cases, you don't really need to treat febrile seizures, but if these occur, they are worrisome to see, but they do not have anything to do with an increased risk of developing epilepsy later on in life. Small infants who experience fever may increase their respiration rates, and that can lead to these febrile seizures. But they appear benign. They resolve spontaneously, and they don't go on and develop into epilepsy later on. So remission is very likely with febrile seizures. Epilepsy that comes on between 2 and 10 years of age tends to have higher rates of spontaneous remission. That usually goes well. If there's not a clear cause, so if it's not you suffer a traumatic brain injury and now you have seizure activity, in those cases, spontaneous remission is less likely. So with no clear cause, you're going to have more likely remission. And then controlling the seizure, not letting them play out and having continued seizure activity. that can increase your risk of having subsequent seizures by allowing them to take place. So controlling them with benzodiazepines can reduce future seizure risk. It can also help keep you alive. That's what we see up here. Early treatment with benzodiazepines. So within 10 minutes, that's this bar right here. I don't even know the color. Some kind of greenish blue. Notice, alive, 100%, dead, there's none there, so no one died in that case. Most people lived if the benzodiazepine treatment was not ideal. It was given after 10 minutes. But as I said, most, we do have some folks who did not make it. So early treatment is better. And by treating your seizures, you can increase the likelihood of complete remission. If left uncontrolled for 4 years, you only have about a 10% chance of ever controlling your seizures. Even for only 1 year, you got a 60% chance. Now, anticonvulsants are only effective in about 7% of cases. So you're approaching the best that you could hope for with that. But as you delay treatment of seizures, your likelihood of ever treating them worsens. So early treatment is important. Hopefully, the reason for that will be clear at the end of the lecture. Do we have any other questions? Yes?
When you said controlling the seizures, don't let them play out, do you mean like when they're having a seizure, you give them the or whatever?
Yes, and then stay on your meds.
Like while they're having a seizure, you give it to them?
That's great. And then stay on your meds afterward, too. So we just sort of tonically inhibit the nervous system a bit to prevent it from having seizure activity. And so once you have controlled seizures for a few years, then they'll taper off the benzodiazepines. And in many cases, seizures don't recur. So you continue taking these anticonvulsants. They might be a benzodiazepine now, be something else. You continue taking your anticonvulsants, taper it off after you've controlled the seizures for several years. So it's not just treated during the seizure and then, hey, everything's fine. It's not a one-time treatment. Excellent question. All right, these are not excellent questions, so I'm just going to move ahead. We only have so much time. Thank you for approving. Okay. So what's hyperexciting our neurons? That's the question. And the answer is totally different depending on who we're talking about. So it's variable. There are many ways of hyperexciting a neuron. Early on in life, febrile seizures might occur. So if infants have if infants have fever, that might then lead to febrile seizures. It could be just simply because of an elevation in temperature. Certainly when you increase the temperature, you're going to increase metabolic activity. You're going to increase just the excitability of a neuron by doing that. If you were to cool the body, you'd see the opposite effect. All activity would slow down. Everything would slow down. It could be that. It's probably not that, though, but it could be. What it most likely is that when we have fever, that leads to an increase in respiration. Hyperventilation increases blood pH, and that increase in blood pH activates HCN channels. And I realize that we haven't talked about these yet. You're going to hear a lot about these next semester. They're hyperpolarization activated cyclic nucleotide gated cation channels. Don't worry about that. Don't worry about that. HCN is all you need to know. After a neuron fires an action potential, it hyperpolarizes. When it does that, that stimulates HCN channels. HCN channels are critical regulators of neuronal excitability. So when you have hyperventilation, that increases pH, and you get an increase in HCN current. That's what we're seeing here. That's that sag. When you hyperpolarize the neuron, you get an inward current. That's going to drive the next action potential. You don't see it if following, when you increase the body temperature of the rat, in this case, that's hyperthermia. If you deliver carbon dioxide, You prevent that increase in HCN current, and you prevent seizures. There's a clinical trial going on to see if this works in people. No results on it yet. But that seems to underlie the induction of febrile seizures. Child gets hot, hyperventilates, increases blood pH, stimulates HCN current, and that causes depolarization of neurons. If you got that, that's good enough. We'll get HCN next semester. Of course, head injury, tumor growth, hematoma, any mass lesion, that can mechanically stimulate neurons. It pushes on them. Everything's mechanically gated to some degree. And then, of course, you'll get some inflammation to clean up damage. That can stimulate neurons. Cerebrovascular disease can contribute as well. If we deprive our neurons of glucose, ATP levels drop. When ATP levels drop, sodium potassium pump doesn't work. Same stuff. Nothing new here. This wouldn't be epilepsy, though. There's a cause. Yes?
So the seizures that are of a different cause than epilepsy, could they be like any of the types, like the grand mal, the T-mal, like that we talked about?
Yes.
Okay.
Yeah, depending on the area that's activated. You're probably not going to see the generalized seizures in that case. It's probably going to be very focal, unless you have maybe a very large hemorrhage or something like that. But stroke tends to be a little more focal. Yeah. In order to see something, especially repetitive, generalized seizures, that's going to be epilepsy. Because these things destroy neurons. These down here, these channelopathies, these just make them hyperactive. So if you have mutations in your sodium channels that leads to an increase in persistent sodium, so you're tonically depolarized, you're not going to die, but you are going to be more active. If you have a stroke, this will kill you. You'll be hyperactive until you die. This, you're just going to have sort of persistent elevated activity. Potassium is particularly important in epilepsy. If you have an increase in extracellular potassium, that's going to prevent potassium from flowing out and hyperpolarizing the neuron. Instead, it's going to want to flow in. And so as you increase extracellular potassium, that's what we're seeing here, the membrane potential, we'll think of this as membrane potential, it's not really, is going to depolarize. And it's not uncommon to see 10 or 15 millimolar extracellular potassium. So you're going to see a 30, maybe 40 millivolt depolarization in that case. That is more than enough to stimulate active potentials. So any alteration of potassium buffering, like reactive gliosis, for example, or glutamate uptake, that can drive this as well. Yeah.
So, like, do people who have these channelopathies, if they have seizures, are they at higher risk for, like, the more neurodegenerative diseases?
Like what?
Like, so, say, like, Alzheimer's or...
Doesn't seem to be the case. No.
Because, like, the hyperexcitability can kill the neuron. Like, does it get to a point where, like, it just, like, the neurons are done, like, at these higher levels?
You can get death of neurons from this, yeah, for sure. It's really variable, though.
Okay.
We don't see any consistent change across epileptic patients, and that's probably because there's no consistent underlying cause. There's so many different ways of hyperexciting the neuron. Oftentimes, the source of seizure activity is the hippocampus. Have we heard of the hippocampus before? Excellent. What comes to mind? What do we remember about the hippocampus? Ah, excellent memory. Yeah. In order to control this epilepsy, early on, the treatment was just cut it out. Just find the source, cut it out. Sometimes we'll do that today. Not always, because it can be devastating. If you cut out the hippocampus bilaterally, so both hippocampal complexes are removed, memory is gone. No new memories are going to be formed. For more on this, Google patient HM. The reason that the hippocampus is so excitable I'd say is multifold. First of all, when we talked about action potentials, we talked about the axon. And that's totally true. Action potentials travel down the axon. But they also travel back up the dendrites in some neurons. Those neurons live in many places. One of the places where they live is the hippocampus. This makes the neurons far more excitable because in the portions where they receive input, they're also firing action potentials. Now, not throughout the entire dendrite here. So here's a nice little hippocampal neuron here. Here's the apical dendrite coming up. Actually, this is a cortical neuron. This is a cortex to me. This is an apical dendrite. You see coming up. It's going to branch here. So as we get further away from the cell body, the propagation of that dendritic spike, or that dendritic action potential, drops off. So here we are furthest away. You only see the dendritic spike making there whenever they block GABA receptors. So usually this is inhibited. If you have a GABA receptor mutation, though, you're not going to be able to prevent that. Your dendritic spikes are going to travel up. And these dendritic spikes seem fairly important for learning and memory, which makes them highly relevant to the hippocampus. Now, as these back-propagating action potentials move up the dendrite, it's just like an action potential going down the axon. We're going to have ion flux. Some will move in, some will move out. We'll get to why that matters in a moment. Just keep that in mind, that we have action potentials going up the dendrites here. Now, in the hippocampus, we need to keep in mind that our dendrites are oriented in parallel. This is from the rainbow mouse, where different neurons in the brain have this random expression of fluorescent proteins. So this is a real image, and that allows different neurons to some appear green, yellow, blue, orange. It's kind of like the rainbow in the brain, hence the name rainbow. So here's our hippocampus. We got our dentate gyrus down here, going up into CA4, 3, 2, 1 is over here. Here's our apical dendrites. Now notice that they're oriented pretty much in parallel. Not perfectly, but they're running alongside each other. There could be a structural abnormality where instead of having slight deviation, you have good alignment of your apical dendrites. Now think about when a back-propagating action potential goes up 1 and we're spitting out potassium. We're going to elevate potassium levels over an extended period. If they're in parallel, which they are, you're going to have greater areas that are exposed to elevated potassium, and thus greater areas that get depolarized. And these dendrites are excitable. So activity in the hippocampus tends to be more robust than other areas. It's a more excitable region. The dendrites can fire action potentials, and they're oriented in parallel. So neighbors can excite each other. It's kind of like when we talk about demyelination. When you have the loss of myelin, then those nearby axons can be excited. That affected transmission. Same thing here, except now we're talking about in the dendrites. So when one neuron gets excited, it's going to spit out ions and maybe excite its neighbors. And then they're going to fire and they're going to reactivate that. And there you're going to get synchronous, repetitive neuronal activity. So the hippocampus is excitable, and that's really important for its ability to encode information, but it also makes it prone to epileptiform activity. And that's then going to be spread throughout the nervous system in a few different ways. The hippocampus is connected to the entorhinal cortex. So that's the cortex that surrounds the hippocampus. And the entorhinal cortex is then widely connected to the rest of the cortex. Alternatively, you can take a short trip from the hippocampus up into the mammillary bodies, then to the anterior thalamus, and from the thalamus, you're going to the cortex. So there are many ways to go from the hippocampus to the cortex. And so when we have this hyperactive activity in the hippocampus, it gets spread. That's what we're going to measure in the EEG, and that's going to cause the sensory, motor, and consciousness abnormalities that we see in a seizure. So the hyperexcitability can be bad. It can also be good, because that is necessary for memory encoding, for long-term potentiation. In other words, the long-lived increase in synapse strength that underlies our ability to encode information. How can we link two ideas together? Here's how. Think of those two things together over and over and over. And the neurons that are allowing you to think those two things will get linked together through LTP, long-term potentiation. We'll go over how this works in great detail next semester. But what we need to understand for this is that when neurons fire synchronously, they are more likely to excite each other in the future. And that likely underlies that increased risk when you don't control your seizures. If you let them play out, if you allow synchronous, repetitive activity of neurons, they're going to strengthen their synapses. They're going to be more likely to stimulate each other in the future. And that's what we see here. So the seizure score with this GABA A antagonist, you can see repetitive injections of it lead to worse seizures. They get progressively worse because you allow that co-activation of hippocampal neurons. When they get stimulated at the same time, they strengthen their synapses. So the next time you activate them, their excitatory synapses are stronger. So you're going to get more robust activation. You're going to get worse seizures. We'll wrap this up. Should we do it Friday? Oh, I got some no's. All right, we'll do it Friday. Kidding, we'll do it Monday. All right, I'll see you Friday if you show up. If you don't, I won't see you. Make sure I get your exams. Have a great day.